Hello, my name is Leah, and I'm here today to discuss everything you need to know about artificial intelligence in cardiac magnetic resonance. During the last 5 years, the amount of research committed to artificial intelligence, machine learning, and deep learning in cardiac magnetic resonance imaging has grown at a rapid pace. Clearly, there is a desire to understand and further the medium. This has taken hold of researchers and clinicians alike. Theoretical algorithms and deep learning software now have a natural home in clinical practice, which can provide extensive quantitative and qualitative data for review. The sheer volume of literature, while encouraging to our radiology community, is cumbersome to comb through and often leaves us with more questions than answers. It is imperative that technologists, cardiologists, radiologists, and many more be presented with current and comprehensive empirical evidence in the exponentially growing field of AI-guided cardiac MR. So where do we begin? Well, this presentation will address the following key elements: the role of AI in cardiac MR and its benefits, the development of AI algorithms and their clinical implementation, and the limitations of AI in cardiac MR with recommendations for the future. Then we will ask a few questions and conclude. Let's start with the role of artificial intelligence in cardiovascular magnetic resonance. There is no denying that AI has an extremely important role in cardiac MR. The literature agrees that cardiac MR exams are invaluable in the diagnosis and prognosis of cardiovascular pathology, and AI applications greatly improve the accuracy and efficiency of those studies. Segmentation of the heart anatomy is a crucial portion of the cardiac MR exam, as it is essential in measuring the volume, ejection fraction, and mass of the heart. Manual segmentation can be subjective or unreliable, as well as extremely time-consuming, which can result in altered prognoses for patients. Utilization of AI in the form of machine learning or deep learning can save time and offer accurate responses in the clinical setting. For example, the time it takes to obtain right ventricular volumes can be reduced by an incredible 87%, and the time it takes to obtain 20 biventricular volumes can be reduced from roughly 250 minutes to just 6 minutes, which translates to approximately 22,000 saved clinician hours per year. Human experts were also discovered to have less precision and consistency than machine learning in measuring left ventricular maximum wall thickness in a test-retest scenario. Machine learning algorithms can more accurately predict patient mortality and median survival time than their human counterparts. Although these algorithms prove their ability to improve workflow and aid in diagnostic accuracy, there will still be a need for a human component in order to validate results. Now let's move on to the development of artificial intelligence, machine learning, and deep learning algorithms. Machine learning is a subtype of AI, and deep learning is a subtype of machine learning. They all have a place in cardiac MR, but they mean different things. AI is a more generalized theory relating to automation of tasks that require intelligence, while machine learning uses mathematical statistics to allow prediction. And deep learning uses layered configurations, like this one here, to learn from raw data instead of requiring continued input from humans. Cardiac MR acquisition has been automated for many years using a software called compressed sensing, an undersampling reconstruction technique that requires less data and time to obtain a diagnostic image. Convolutional neural networks are a subtype of deep learning and utilized most often in automated imaging software due to their ability to learn automatically and extract desired features. Fully convolutional neural networks, Recurrent neural networks, autoencoders, and generative adversarial networks are other important subsets of deep learning that can be developed for improved image synthesis, more accurate training, and increased precision in segmentation. An excellent example of a GAN model, is seen in this study performed at Stanford. The authors utilized this deep learning method to pre-train segmentation with the concept of transfer learning, which is a strategy of taking a tagged cine image and transferring that data to other cardiac MR images to teach the software how to automate tagging in the future. This was an important addition to the literature, proving that pre-training software allows for improved performance and efficiency. Now that we've covered roles and development, let's discuss the limitations of artificial intelligence in cardiac MR and its important next steps. Most of the studies being performed in the last few years are limited by their small cohorts. Although their results are not to be diminished, a sample size of just 60 participants or even 100 participants is not large enough to definitively apply to larger scales. Therefore, it is highly recommended to engage in a wider range of patient demographics, inclusive of different ages, diagnoses, implant types, gender, and geographic location. As of right now, a 1.5 Tesla Siemens scanner is responsible for the greatest amount of clinical supporting data. It is important to encourage the utilization of multiple scanner types in future studies, both in vendor and magnet strength, to accurately decipher the benefits of commercialized AI-guided cardiac MR. Another limitation is that the development of deep learning algorithms can be time-consuming, and the literature has not yet decided if the cost of deep learning segmentation software outweighs the cost of increased throughput due to automation. In addition, actual clinical benefits can be a bit vague and dependent on characteristics that are not as easily achieved in most clinical settings. There is also no specific standardization for the development of AI algorithms. Many research sites adapted known software or formulated their own. It is important, therefore, to keep sharing the format utilized in future research in order to accurately assess future works. It is encouraged that new experimental software follows certain guidelines, especially when it comes to the privacy and protection of patient information. It will also be a necessary eventuality to have FDA approval to further the commercialized use of machine learning and deep learning algorithms. Now, let's ask a few questions. Question number 1. What is the AI chasm? Well, many theoretical advances in machine learning and deep learning fall prey to this so-called AI chasm. This is the idea that accurate algorithms, while extremely impressive, have limited clinical applications or capabilities. Basically, we can develop new and exciting algorithms, but how much of it is clinically relevant? Question number 2. Why is 1.5 Tesla the preferred magnet strength for cardiac MR? Well, research performed at higher magnet strengths may not be as helpful as one would expect, as heart motion, blood flow artifacts, breathing artifacts, and metallic artifacts become more common in a stronger magnetic field. Patients with certain implants, such as an MR conditional cardiac pacemaker, are able to have their exams in a 1.5 Tesla magnet more often than compared to a 3 Tesla. To stay compliant with safety protocols and adhere to specific AI requirements with less artifact, 1.5 Tesla is the preferred magnet strength. When we discuss AI-guided cardiac MR, it is with the knowledge that we have already been using it for quite some time in the form of compressed sensing, automated protocol selection, detailed auto-alignment of images, and automatic post-processing. We have much more to accomplish, especially in uniformity of standardized widespread clinical adoption. However, the ability of AI in the form of machine learning and deep learning to successfully automate measurements and post-processing is growing ever more rapidly and shows great promise in clinical settings. Most literature has come to the agreement that automated segmentation and more dedicated deep learning based post-processing in cardiac MR is a worthy and attainable goal. Of course, AI in medical imaging won't be replacing humans anytime soon, as we will still be an integral part of the patient experience. Focus should now be placed on the standardization of algorithm strategies in larger cohorts. Many more retrospective and prospective studies need to be performed to prove reliability, validity, and ability to integrate AI into appropriate workflows. Narrowing the scope will also play an important role in future projects. Developing key deep learning and cardiac MR protocol optimization and implementation, evaluating the ability of deep learning software to learn and adapt to different pathologies and artifacts, and consistent quality control measures, both manual and automated, are all specific, actionable paths of potential research. Thanks for your time.